Good afternoon, everyone, and welcome to our Facebook Live today, where we're talking about a more rare type of cancer, but an extremely important type of cancer with a lot of scientific changes over the last couple of years. We are going to talk about anything and everything that you want to know about a type of cancer called mesothelioma. And I'm going to ask you to pardon me for just a second. I'm going to put my glasses on and read to you because our guest today, who's going to help us really understand this cancer, has a very impressive bio, and I want you to know who he is and where he is coming from. Dr. Rupesh Kotecha is a board-certified radiation oncologist. We're going to talk about what that means in just a second. He's also the chief of radiosurgery in the Department of Radiation Oncology at the Miami Cancer Institute, where he is also director of the Central Nervous System Metastatic Cancer Program. He has specialized training and experience in utilizing the latest techniques in radiation therapy for both cancerous and non-cancerous conditions. And I also think that that's important to think about. He's treating both people with cancer and people who don't have cancer using specialized radiation therapy. He does advanced radiation therapy treatments, which include proton beam, MR-guided radiation therapy, and he has been an invited guest speaker at a number of both national and international symposiums. The exciting thing as well is that Dr. Kotecha, I'm going to say hi to you while I'm telling our listeners, our folks here on Facebook, that you are very widely published. So you have over 75 articles and you've written book chapters and have really shared what you're learning about treating people, both with cancer and non-cancer, widely. And that's incredibly important because it really helps grow the next generation of researchers and people who are treating people with cancer. So I know that that is not an easy task to do all of that work. And I just want to recognize and thank you for doing that. And welcome today to our little Facebook Live here.
Well, thank you so much for having me, and thanks so much for that kind introduction. I really appreciate it. Very happy to be here and share any of the information and updates that we have in the medical field on this important topic.
Yeah, well, thank you. And we're going to get into mesothelioma in just a second, but I want to just step back and share with our listeners what kind of a doctor you really are and why you're so specialized. And again, you know, you and I have talked about this before, that I've been in oncology for about 40 years now, and things have changed from that beginning, certainly. And I would love for you to just talk about your specialty and why it's so important now, and why things have changed to the degree that there is this level of specialization.
No, absolutely. So radiation oncology, which is the field that I subspecialize in, is actually a specific subset in oncology. We actually do training. I actually did specific training in some medical oncology and surgical oncology, and then did a training program specifically in radiation oncology. Now, as we think about treatment options for cancer patients, the categories that we typically use are radiation oncology to deliver radiation therapy treatments to patients, then medical oncology, which is in the area of targeted therapies, chemotherapy, immunotherapy, and then we have surgical oncologists, which sometimes, for example, are thoracic surgeons when we're thinking about mesothelioma or other types of lung cancers, or could be, for example, brain tumor neurosurgeons when we're thinking about malignancies in the brain. The three specialties really work together with other aspects of oncologic care, such as palliative medicine, cancer rehabilitation physicians, to really give a multidisciplinary approach to each patient who has cancer. Now, at our facility, and you're increasingly seeing this throughout the United States and the world, is that physicians are then site subspecialized after their training in their respective specialty. So for example, for myself, I specialize in treating thoracic malignancies or cancer in the brain and spinal cord. To some degree, that's because a majority of cancer that we see in the brain is actually metastatic disease that comes from the thorax, from the lung. And so therefore, working in those two specialties is actually overlap for patients who need treatment in both those sites.
Great. I want to just start, I'm just taking a quick note to remind myself to go back and ask you something about mesothelioma. Let's start with what is mesothelioma. And the note I was writing myself is to remind you to differentiate between mesothelioma in the chest or mesothelioma elsewhere. So do you want to just step back and talk about what is mesothelioma from the beginning?
Absolutely. So mesothelioma is a very rare type of cancer that involves the lining of certain organs in our body. The analogy that I commonly use to patients is that if you think of the organs, for example, the heart, the lungs, as an orange, again, we're here in Florida in Miami. So if you think of them as an orange, you have the orange itself, which is the organ, and then the peel of the organ, which is the lining of the organ. And most of our organs in our body have that component. They each have their own lining of their organ. Mesothelioma is a cancer of that lining. It's of the peel of the orange, not of the orange itself.
Mm-hmm.
This can happen in the lung, where we see it most commonly, about 70 to 80% of cases, but it can also happen around the heart. It can happen arising from the abdominal cavity or even the pelvis. But again, most cases are malignant pleural mesothelioma, which is the medical term for a cancer of the lining of the lung.
Mm-hmm. And so for the purpose of today, we are going to focus on pleural mesothelioma, which could also be called MPN if we want to shorten it a little bit. And so if I hear you right, it's different than a lung cancer.
Absolutely. So a lung cancer actually starts in the lung itself. It then typically spreads to other lymph nodes in the center of the chest, maybe some lymph nodes in the lower neck. It then can spread to the lining of the lung, either via direct extension for a tumor that is localized right at the edge of the lung tissue and is then growing into the lining of the lung and potentially into the chest wall or the ribs. On the other hand, it can also just spread to the lining of the lung, which is known as a pleural metastases, or a cancer spread deposit that is gone to the lining of the lung. This is different than mesothelioma, which starts in the lining of the lung, can grow interior on the inside, can also spread to lymph nodes, and can spread to other sites, but this site of origin is different between the two.
So what are the risk factors for people to develop a mesothelioma?
Sure. So the most common risk factor that we know of, and this has been established by the American Cancer Society, is a prior history or exposure to asbestos. Asbestos is a particle, a chemical compound that was used for a number of years in a variety of industries, anything from shipbuilding, brake repair, working on ceiling or pool tiles, any type of manufacturing, construction. All of those could be associated with asbestos exposure. Some people, even by working in a boiler room of a ship, have had that exposure in the past.
Mm-hmm.
Unfortunately, sometimes we don't know that direct link or when it happened because there is a considerable latency, a difference in time from when a patient was initially exposed to asbestos and then develops mesothelioma. On average, that latency is about 30 years. So if you think of 20 to 40 years ago that you're trying to search in your history, maybe it was working an odd job where you don't remember at an early age, those things come to light. Now, if we look at cancer records, about 70% of patients that we see in the clinic with a diagnosis of mesothelioma, we can directly identify their kind of source and prior exposure.
Mm-hmm. A couple things that I want to make sure and speak to is that we've been able over time to also trace mesothelioma that's due to asbestos to not necessarily the person who's been working in that environment, but their family members, right? Because there's a belief that the asbestos fibers are, available and might have been, released into the air and inhaled, during laundry or other things. Am I sort of right on that?
Yeah, and actually there's some nice population-based studies that have been done looking at people living around areas in which asbestos was potentially manufactured, and just the extent of exposure, how many years they lived in that area, and their proximity, their closeness to that actual facility manufacturing, those can also be linked in. And so we're learning a lot about those exposures and that link. Now, fortunately, the use of asbestos, although it's excellent for insulation and other reasons in regards to manufacturing, because we understood that link, we have been reducing the use of that. And therefore, in the United States, for a number of years now, we've seen that risk go down and down over time. It's something, though, that in the rest of the world, we're still remaining cognizant about the use of this. And so that's why that relationship is really important to solidify and understand better.
Mm-hmm. Mm-hmm. And for our listeners, again, you and I did a radio show a few months back, and we'll make sure and put the link in the notes so that if you want to, you can go back and take a listen to that. And we had talked about the incidence rates of mesothelioma and whether we would start to see those dip. And I thought that your comment was really interesting, that even though asbestos has been illegal now for a long time, we've not used it here in the United States, we're still seeing some of the results of that because of this 30-year window of time.
Yeah, that 30-year latency, I mean, it's a late lesson. It's a hard lesson to learn, but it takes a long time for us to demonstrate that connection.
Yeah. So for those who are listening who think, gosh, I might want to just be aware of symptoms that I might experience, what are those symptoms that you normally see people present with?
Now, this is a very rare diagnosis, and the symptoms are really not specific for a majority of patients that we see in the clinic. Patients typically present to their primary care physician, maybe the emergency room, but more often these are kind of chronic issues where they develop cough, shortness of breath, difficulty breathing, sometimes hoarseness in the voice, sometimes some difficulty swallowing, and then what we call constitutional symptoms, kind of generalized symptoms, where you're feeling fatigued, maybe you're losing weight, you have a reduced appetite, maybe some night sweats. Now, if I list all of those symptoms off, I know a number of the viewers in the audience will think of all of these other medical conditions not related to mesothelioma that have those same symptoms, that share that symptom profile. And those could be cancer related, such as mesothelioma or lung cancer, and they could be non-cancer related. Imagine what is going on in our country right now. A lot of those symptoms, people initially present to the emergency department, and they may be diagnosed with a virus or potentially now a flu in the current season. So we can't always think of directly mesothelioma. There's not one specific factor or symptom that says, hey, this patient has that, but it requires that symptom burden, a workup that's appropriate, imaging, a biopsy, and then we can make that diagnosis of mesothelioma and then discuss the treatment options.
So we have a slide of a scan that shows mesothelioma. So I'm going to have you tell us, what are we seeing here, and what is this exam? So when you think about how it's diagnosed, kind of walk us through how it's diagnosed and what are we looking at?
Sure, absolutely. So this is a patient who came to our clinic with a right-sided mesothelioma. Now, as you're looking at scans, in the body, most of the organs are paired. They're matched right side and left side. So an easy comparison is just to compare parts on the right side of the body to the left side of the body to help identify any abnormalities. The scan on the left is a picture where the patient is imagining themselves looking at themselves in the mirror. So the right-hand side is actually the left-hand side of your screen, and the left-hand side is actually the right-hand side of the screen. So it's almost as if it's from your perspective. Now, as you can see, just looking at the left-hand picture, you see that there is a lot of black on one side, but then on the right side, there is a substantial amount of gray area. And it's almost like that is encasing a very small black circle or really an amount of area. And that's the patient's residual lung that is functioning. On the right-hand panel is a CT scan, which is an axial slice. Imagine a cross section, as for example, if you're cutting a loaf of bread. On the right-hand side is the disease that is encasing the lung. Again, the lung is black on this particular CAT scan. And then on the left, you see just black. And that should be what a normal lung looks like. The lining of the lung should be so thin on a CAT scan that we should not be able to see it. I should just see the lung itself in black, and then I should see ribs, which are on either side, and chest wall, muscles, things like that. On this scan, though, you can see that the right and left are not symmetrical, and there is disease encasing the lung, in which this patient was then diagnosed with mesothelioma.
And so this is a CAT scan. Is this primarily the tool that you use to diagnose a mesothelioma? And we can take the slide down for now.
Absolutely. So it really differs depending on in which situation the patient is presenting to clinic. So sometimes they're acutely short of breath because in addition to having mesothelioma, they may develop fluid in the lung known as a pleural effusion. It's very common with mesothelioma, can happen with lung cancer, can happen with other causes as well. And so if that's an acute change, they may get a chest x-ray first, as it's a quick scan, tells us if something immediate is going on in the lung that needs intervention. But a majority of patients, especially in the modern era, require a CAT scan to really determine what's the etiology of the patient's symptoms. And that CAT scan will at least give us a picture that we can be thinking, is this a cancer or non-cancerous condition? And then from there, we do additional imaging studies and biopsies to determine the diagnosis of mesothelioma.
So I have a question for you. When you're diagnosing somebody with lung cancer, for example, you'll do other PET scans and things to see if it's spread through the body, and then you can stage it, stage 1, 2, 3, 4. How does that work with mesothelioma?
It's a great question. So with mesothelioma, we actually do use a PET scan as well for systemic staging of the body. That PET scan can help us to tell, for example, if a patient has small lymph nodes in the center of the chest, could those be involved? Or are they reactive because the patient's underlying other lung issues? And they also help us to determine if there's any other disease that's outside of the chest itself. Sometimes patients can have disease extension below our diaphragm, the muscle that separates the chest from the abdomen. Sometimes they can have lymph nodes in the abdomen. And so we can pick up those on a PET scan. So similar to lung cancer, we use a PET scan as well. We do not need to do, for example, an MRI of the brain for mesothelioma because lung cancer, this can commonly go to the brain, but we don't see it with mesothelioma. So typically patients have CAT scans, they have a PET scan, they will undergo a bronchoscopy, which is a camera down into their throat, biopsy. Sometimes we get biopsies from the outside, and sometimes a surgeon has to take them to the operating room and actually do an open biopsy to get enough tissue so that we can make that diagnosis. Sometimes that diagnosis is known a little bit earlier on by just removing fluid from the lung, and we can see floating mesothelioma cells. And then finally, we need to do a workup to see what the patient would be a candidate for with regards to their medical comorbidities. Because remember, exposure to asbestos not only leads to cancer, but also leads to other respiratory issues. And these patients may have underlying lung issues not related to the cancer, but that we need to think about when we think about treatment options that this patient can undergo.
That makes a lot of sense to me. And then so do patients hear the word stage? You're a stage 2, stage 3, stage 4?
Now, for all patients with lung cancer, we do give them that stage, and that really dictates their treatment paradigm. The AJCC, which is the American Joint Committee on Cancer, also has a staging system for mesothelioma. So we do give patients a stage. But for mesothelioma, really the treatment paradigm is one of 2 pathways. And so although the advanced patients would get one pathway and the early stage patients may get another pathway, even if you are an early stage patient, if you cannot have surgery, well, then your treatment is the same as if you were locally advanced. And so although we do have a staging system, really in the sense of treatment paradigms, there's really either we're going to use surgery in this case and then discuss the treatments they may need before or after surgery, or the patient is not a surgical candidate and that they're not medically operable, or their disease is not surgically resectable, and then they are treated with chemotherapy, radiation, and some other treatments that we have as well.
Okay, So let's dig into treatments, and we're going to take you outside of your field a little bit and talk about surgery, and then we're also going to talk about medical oncology, and then we're going to move into where your specialty really is. And I just want to remind our viewers that if you have questions, please feel free to enter those into the chat, and we'll do our best to answer those for you. We're not going to talk about specific patient cases because you don't have all the information you would need to address a specific patient. But we could certainly make sure that we can connect you guys at some point in time. So what I heard you say is early and late phase disease, and early phase is treated with surgery. So what does that look like? Is it literally peeling the mesothelioma? You know, if you go back to the analogy of the orange, or is it removing the lung? What do those surgeries look like for early stage patients?
Great question. So there's actually a spectrum of the type of surgeries that we can offer patients who have mesothelioma. And again, these are for patients who are medically operable, who can undergo the resection. And the traditional surgery, so I say on this end, would be to do an extensive surgery in which patients have the tumor removed, the remainder of the lining removed. They could have the lung itself also removed, the lining of the heart removed, and then the diaphragm, which is again that muscle that separates the chest and the abdomen. And then there is a mesh that is placed to make sure that your abdomen contents don't go into your chest. All of those structures are removed. That is a very extensive surgery that is associated with a potentially higher risk of morbidity, side effects, and mortality, death. And so we have moved along the spectrum to offer a less extensive surgery, and that would be to remove the tumor itself and then strip the lining. So as you mentioned, maybe just remove the peel of the orange itself. That's what the issue is. And to leave the lung itself intact. That is a less extensive surgery that is more commonly done at our center and centers around the country and world.
Okay. And then for people who are not a surgical candidate, and maybe just take a second and speak to why they wouldn't be a surgical candidate, and then let's talk about what their options are there.
Sure. So deciding a surgical candidacy and really treatment paradigm is what we do in a multidisciplinary setting. So you see all of the physicians, and then we make a determination as to what would be the optimal treatment paradigm. Now, when we're thinking about candidacy for surgery or resection or that pathway, we think about what's the histology of the mesothelioma. There are some histologies that have a better prognosis than others, and so a more aggressive histology would we really take to surgery. The second is we think about the performance status of the patient. Patients may be compromised already from the mesothelioma effect on their body. They may have lost weight. You can't take a patient to surgery who's lost 100 pounds over the last 2 months. Third is that we have to think about what are the other medical comorbidities does that patient have? Do they have good heart function? Do they have good lung function? If you were going to have to remove the lung, would they be able to survive and function on just one lung alone? Fourth, we have to think about what's the local extent of disease that the patient has. If you have a mesothelioma just arising from the lining of the chest, but it goes through 4 ribs, well, that's going to require an extensive surgery removal of the chest wall resection. So those are all the types of things that we have to think about before offering a patient a certain paradigm.
So let's talk about what at least my perception is sort of one of the next steps, and that is, or let's just talk about the historical perspective, and that is treating the mesothelioma with drugs, right? Drug therapy in some way. And this takes you a bit out of your field, but I know that, and you started to speak to this, but I know that you have multidisciplinary conferences. So you are a part of all of those conversations when you're looking at treating a patient. So what take us inside of one of those multidisciplinary conferences and those conversations, and how do you decide for people who aren't surgical candidates what those next steps are, and share with us what those are?
Sure. So right now, if a patient's not going to surgery, we would first determine, does the patient have any local symptoms from their disease? So even if they're not going to go to surgery, but they have, for example, a chest wall mass causing them localized area of pain, well, then we discuss that we would offer that patient radiation therapy treatments. And typically here we do 10 fractions of radiation for those patients. Sometimes it can be even shorter as 5, or even as short as 1. But we can give radiation treatments to give the patient palliation to improve their pain control, other than just using medical therapy, using opioids alone. So that's one decision that we have to think about. The second is the chemotherapy standpoint. Now, typically the standard of care is to offer a doublet chemotherapy regimen, and that's the last FDA-approved therapy, which was done about 16 years ago, actually. And that doublet regimen has been used for a number of years. And so in patients who are even elderly, there are modifications that can be done to that regimen, but patients typically get between 4 to 6 cycles of that therapy, and then they may receive some maintenance therapy every so often after that completion. Now, some patients can also receive a 3-drug regimen as well. There have been some trials using that in the United States. It is on the NCCN, our cancer center guidelines, throughout the country, and is used, but not universally throughout the world, because that third agent is not always available. Mm-hmm. And then we think about, is the patient a candidate for example, tumor treating fields therapy, which is a therapy that is used, applied to the chest, in addition to the doublet chemotherapy agent. And then excitingly, we now have new treatment options. We go through all of these, but we now have immunotherapy, which has been FDA approved very recently, just about a month and a half, 2 months ago, that is going to start entering the clinic soon, which is another alternative regimen that patients can be offered.
So again, I just want to sort of repeat what I'm hearing you say. So we've talked about surgery, and now you're talking about using drugs, radiation, and specifically tumor treating fields, and we're going to talk about that in just a second, and then new immunotherapies. And the question that I have about that is, are we talking about administering them sequentially, one at a time, or can patients get more than one of these treatments at the same time? And is there one way that's more effective than the other?
Sure. So typically when chemotherapy is administered, that is going to be the primary treatment. And sometimes if a patient is going to receive radiation therapy treatments, we try and schedule it so it can be done before and afterwards, or intermixed with the chemotherapy treatments. Because chemotherapy is given in cycles every X number of weeks, say 3 weeks. Now, the immunotherapy infusions, they potentially can be delivered more safely with the radiation if we're delivering them at the same time. We haven't, again, used this in mesothelioma as much, but we've used them in patients who have recurrent disease who've already had chemotherapy, and we sometimes give radiation with their immunotherapy. The tumor treating fields therapy can be given with chemotherapy. It has not been tested yet with immunotherapy. There are going to be some upcoming trials in the future that are potentially going to be looking at the combination. So those are some of the sequencing and combination strategies that we have to think about in the clinic.
Okay, so let's pull up a couple slides. And I think that this is exciting new information. When I think about what's on this slide now, this gives our viewers a sense of what you deal with every day, right? The type of tools that you have available to you. And can you just speak to, you don't have to go through each of these, but can you just sort of speak to, is this past, present, future? And then we do have, when you're ready, the tumor treating fields, and we can show folks what that really looks like.
Sure, so absolutely. So as a radiation oncologist, again, we use radiation therapy to treat patients who have cancer. And as you can see here, these are basically just the pictures of the arrays of technologies that we have available at Miami Cancer Institute, which is where I work. So we have conventional linear accelerators that you can see in the top left-hand corner. We have what's called the CyberKnife machine. It allows us to even give robotic radiation therapy with very high precision. We have the third machine, which is the Radixact tomotherapy. In that, it's a CT scanner also with a radiation machine inside. So the patient actually just slides through the machine. It is constantly rotating. It sees what we're treating and then treats it. The Gamma Knife allows for high precision radiation in the brain. An MR linear accelerator actually allows us to have an ongoing MRI while we are treating a patient. And in fact, we can actually turn it on so a patient can see their tumor being treated with radiation while they're actually having the treatment. Brachytherapy, low dose and high dose rate, is when we implant radiation in a patient, either temporarily or permanently. And then the last one is proton therapy, which is a newer form of radiation therapy using particles of protons. And so these are all the options that we have here. We actually personalize it for every patient, depending on their cancer type, the extent of disease, are they going to receive chemotherapy, all of the information we put in to really personalize which radiation machine, which treatment option is best for that individual patient.
Mhm. And this slide just underscores for me, when I talk to people who are newly diagnosed, and I'll say, look, this is not your grandmother's cancer anymore, because we have so many tools, like you said, to personalize, and not just the radiation therapy, the chemotherapy and immunotherapy and all of that. This just really underscores that for me. Let's just move to the next slide, because I know that you've mentioned a couple of times these things called tumor treating fields, and walk us through what this is.
Sure. So tumor treating fields are one of our treatment strategies for patients with newly diagnosed mesothelioma, and these are delivered along with chemotherapy. Essentially, these are delivered using transducer arrays that you can see pointed out here in the bottom left. Those are applied to the chest of a patient. We personalize the type of arrays, their placement, for example, on the front, on the back, or on the sides, really depending on each patient's disease, their gender, their size, any ports, for example, that are placed. So we really personalize where those arrays need to be placed. Those arrays deliver alternating electric fields, and those fields are able to pause the mesothelioma cells and to pause them from dividing, from growing. And the rest of these items here are what are used to really power this. Again, you can see a portable battery charger, the batteries that are used to deliver this, the field generator itself that is generating these alternating electrical fields, and then the backpack that patients wear that basically has this device housed into it.
Mm-hmm. And I think we have another slide that shows where the
Absolutely. So this is a patient of mine with mesothelioma, and these are the transducer pads that we designed for that patient. And so you can see here, there's one on the right chest, there's one on the right side. You can see the back pad and then the left side of the chest. So again, these are personalized for each patient. This patient had some disease that was extending lower, so that's why the lower placed pads on the sides. But then basically these ensure that the energy is delivered to the area of the disease. The way that alternating electrical fields work is that there's a certain frequency that these are set to. That frequency is known in the lab, so imagine a petri dish, to help pause those mesothelioma cells from growing. So we know which frequency is tuned particularly to which cancer type. And we know that mesothelioma cells in the lab are sensitive to these tumor treating fields.
So you keep using the word pause the cancer cells. So when you think about chemotherapy, radiation therapy, we're talking about killing the cancer cells. This type of treatment pauses the cancer cells. And what's the difference in that for the patient?
Sure. So when we're thinking about a patient who's not going to have surgery, chemotherapy, radiation, tumor treating fields therapy, all of these treatments that we have are really to slow the progression of the disease. It is nearly impossible to really get rid of all of the cancer in the body when somebody cannot go to surgery. And even when they can go to surgery and we give radiation and chemotherapy, we still have a high risk of disease relapse. It will still come back. Mm-hmm. And so all of these treatments to some degree are to help delay the progression, let the patient live longer, and also quality of life is an important component to that as well. We want them to live well for a longer period of time.
Mm-hmm. Okay. And I do think that we have a couple more slides that show, I don't know if it's the same patient or another one of your patients here, of how they look before the treatment and after the treatment.
Sure. So these are the axial CT slices, axial being sandwich cross-section site. So imagine just a slice through here. And as we shown on the first image, it was a mesothelioma on the right side. So hopefully on this, we can see it's on the left side. And you can see that encasement of the lung itself. Again, the lung being black. So the lung is black on the right, and on the left, it is a smaller area. It's asymmetrical because of the cancer. This is the pre-treatment CT scan on one side, and then on the other side, their post-treatment CT scan. This patient received 4 cycles of carboplatin pemetrexed which is the standard chemotherapy, and also used Tumor treating fields. And as you can see on their post-treatment images, that cancer is starting to regress, to shrink back into the chest wall itself. So we had a good response to the treatment.
And then the next slide.
This is lower down in the chest. So again, if you're looking at the asymmetry between the right and left side, on the pre-treatment imaging, it is located next to that rib and vertebral body, that thickening on the medial part, the center part of the left lung. And then if you look at their post-treatment imaging, that is starting to regress and thin down more.
Mm-hmm. Yeah, thank you. And I think we can take the slides down now. Thank you. So just to, summarize some of the things that we've talked about, and I know that we have a couple of questions that I want to run past you. It's exciting. This rare cancer, there's been investment in treatment, and it's exciting to see what's really happening. If patients are interested in talking to their physician about this comprehensive suite of options, how would you recommend they go about that?
So I think there's a number of foundations and societies that can help coordinate care for patients. I think doing some research and really asking your physician, do you have a coordinated team that can help approach my particular cancer? And this is for mesothelioma, could be for other rare tumors as well. But I think every patient right now is seen, evaluated, and their treatment paradigm is discussed in a multidisciplinary setting. And so you have all of the options available for a patient to decide, because I think out of all of the decision-making points that we think about for cancer care, we never have to forget patient input. There are some patients who can receive surgery or radiation for, say, an early stage lung cancer, and they don't want to go to surgery. Some patients do want to have the tumor out of them and they don't want radiation therapy. So I think we have to take that patient input. So I think if you discuss with your physician, ask them about all of the options. And specifically, I always encourage enrollment onto clinical trials to help for a patient to potentially get options that are new, just being tested, and then also to help us advance science forward for especially rare diseases.
Mm-hmm. And let us just say that if you're on a clinical trial, I think there's still this misperception that if you're on a clinical trial, it's a last-ditch kind of effort, and it is not that way. If you're on a clinical trial, you're getting at least the standard of care and more.
No, absolutely. And I think, when you're on a clinical trial, I would always ask your physician about what are the benefits and risks of being on a clinical trial. And sometimes some of the benefits, even if you receive what we would think of as the standard of care, what you would receive if you're not in the study, you could potentially get extra imaging that is covered by the clinical trial. You get extra appointments. Here you have a research nurse and a coordinator that is assigned to your case. So even if you're going to have the regular appointments, you have somebody extra on the team to make sure you are making every one of those appointments an extra point of contact. And sometimes just that can improve the cancer experience for any patient.
Yeah. We have a question from one of our listeners around complete recovery with mesothelioma. When you're thinking about goals of therapy, have you seen people who have had a complete recovery from their mesothelioma, or are we looking at prolonging life and quality?
Well, when we think about it, about a third of patients, maybe 20%, can go to surgery. And so there is a chance for a cure in those patients who have surgery, chemotherapy, potentially get radiation therapy treatments. And so although it's small, there is a chance that those patients diagnosed early, have aggressive treatment at a specialized center, can have complete recovery or essentially cure of their mesothelioma. Mm-hmm. Unfortunately, a majority of patients will have advanced disease at the time that they're diagnosed. Therefore, they're treated with chemotherapy, radiation, tumor treating fields, or even immunotherapy to help prolong their outcome. I think with the advent and additional use of immunotherapy, it's something that we're always thinking about and really hoping for. As we look for long-term outcomes of the immunotherapy trials, we may see that a little bit more. But again, the new survival data with the novel immunotherapy agents that are available that have just been approved as of 2 months ago, I think are really going to be game-changing for this.
Yeah, I agree with you. And we have a question from Diana that sort of is backwards into this, because what I'm hearing you saying is early diagnosis is best. And Diana's question is, are there any particular screening options, especially for people who are at higher risk?
Sure. So I think, right now, because mesothelioma is such a rare diagnosis, again, only 3,000 Americans in the United States actually get diagnosed with this, we don't have screening measures. You think for a lot of cancers, we actually don't have screening measures because cancer itself is rare. But when a patient's diagnosed with a cancer, there are a number of cancers that a patient could have. And so although there are no screening measures for mesothelioma specifically, a lot of patients actually have enough features in their history that they may warrant screening for lung cancer. So for example, use of smoking history plus family history or even exposure to asbestos counts as one of the factors, and that a patient could get screened for a lung cancer that may diagnose a mesothelioma in the future instead, but really the screening is done for the more common cancers, such as lung cancer. But again, I encourage you to discuss that with your primary care physician for your particular history and your risk factors to warrant any additional evaluations.
That's fair, thank you. Is there anything else that you can think of that we haven't covered today as we come to the end of our time together?
No, I think, the future is very bright. There are a number of ongoing clinical trials. There's confirmatory trials that are being launched that are looking at combination of chemotherapy and immunotherapy. So we've seen some patients benefit from chemotherapy. In the immunotherapy trials, although we saw an improvement in overall survival, as we start to look at the subsets of patients, not every patient benefits the same amount. Some patients are benefiting more, some patients are benefiting less. And so we need to determine who needs chemotherapy, who needs immunotherapy, and potentially some patients may need both. In lung cancer, we use some molecular factors to then determine which patients should get immunotherapy alone, which patients should get chemotherapy plus immunotherapy. And I think we need to learn that in mesothelioma. So there are ongoing trials that are being launched in this space. Question of combination approaches also approaches tumor treating fields. Should immunotherapy be used with tumor treating fields? Should we use other regimens in this space? There are other novel immunotherapy agents being tested as well. So I think there's a number of interesting and new studies that are really trying to push the envelope for this disease. And so for any patient newly diagnosed, please talk to your physician about all of the options: surgery, chemotherapy, radiation therapy, but also clinical trials, because they may open the door for new treatments that are not being thought about or discussed.
Great. And then I will put a little plug in. Our website is www.cancersupportcommunity.org. And we have a lot of material there. We have material on mesothelioma, but importantly to what we're speaking about right now, clinical trials. And we've got booklets that talk to you about what a clinical trial is, what questions you should ask, how you should tee up the conversation with your healthcare professional. And then we also have a telephone helpline, and that number is 888-793-9355. And you can talk directly with someone about how you sort of work through the process of communicating to your healthcare team about clinical trial or other potential options. So I just want to throw that out there as a resource to folks. I want to quickly thank our sponsor for today's show, NovoCure, and they've been a very generous sponsor and a leader in really thinking about what is the next generation of treatment for mesothelioma and other cancers for sure. And then Dr. Kotecha, you have been so generous with your time, not only here, but also on our radio show, which is hosted on Voice America. And I just want to thank you for that. And if we have anyone that wants to get a hold of you, we will take their information and make that connection for them. I just want to put that out there as well.
Well, thank you so much for having me here today. And actually, thank you so much for letting me be part of the cancer support community. I really appreciate it.
Thank you. It's our pleasure. And we will talk to you soon.